Afternoon, everyone. Okay. First glitch, let some sound reverberation. God. Okay, hello everyone. That's better. Right. Got to speak. Right, hello everyone. Okay, we're getting some sound bouncing back and it's really off-putting everyone. So we're just trying to solve that problem now. Just to let you all know, we can't live stream this meeting, but it will be recorded. So I think we may have solved the sound problem in this room. So let's try and get started. I know we've lost quite a bit of time this afternoon, so I do apologise for that, but technical problems crop up and there's nothing we can do about it. So welcome everybody to this afternoon's meeting of the Solihull Health and Wellbeing Board. As I said, we're not being live streamed, but we are being recorded. So if everybody can bear that in mind. We have a full agenda this afternoon, so we'll try and get through as much as we can in the time slot. So first of all, let me just tell you who is in the room. So I'm Councillor Karen Grintsall. We have another Karen Helliwell, who's here from BSOL CCG, Ruth Tennant, Jenny Woods, and from our voluntary and community sector, Anne Hastings. So they're the people in the room and I can see you all on the screen. So we'll usual procedure, put hands up if anybody wishes to speak. So we'll crack on with the agenda. And first of all, can I take the apologies from Joseph, please?
Thank you, Madam Chairman. Just to confirm, apologies, Yvonne Buckland and Will Taylor from the CCG. Councillor Richard Holt and Councillor Fiona Hughes from SEH.
Okay, Joseph, do we have any declarations of interest? Members, do we have any declarations of interest? Okay, questions and deputations, and I believe there is a deputation for this afternoon.
Yes, thank you, Chairman. Received a deputation from the Monks Path Patient Participation Group. The deputation reads as follows. On the 15th of June 2021, the board received a presentation by the Birmingham Solihull CCG entitled Outcomes from the Solihull Healthcare Partnership Access Independent Review, and the presenter used a PowerPoint with 8 slides. The 15th of the June minutes refer to the CCG providing a copy of the report later, and on the 16th of September, the Monks Path group discovered no report had been provided, so we supplied one to the board support officer where it could be found online. The Monks Path group used a Freedom of Information request to obtain a copy of the independent review document, which was received on the 20th of August 2021. SHP published the independent review document on their website on the 12th of August. A second Freedom of Information request was required to obtain a separate short report by a contractor on the private Facebook group SHP Patients. This was received on the 20th of the 9th. The Monks Path group wish to make a number of critical points to the board. For the PowerPoint presentation, slide 4 states, SHP have delivered services to patients 24/7 throughout the pandemic. This is factually wrong SHP do not provide this level of service. In 2004, the GP contract was negotiated and extra hours ended. Slide 5 refers to a Facebook website is inappropriately presented as belonging to the NHS. The moderator of SHP Patients was aware of criticism in March 2021, and in May 2021, Facebook had a complaint, and he sought NHSE views in June 2021, who replied it was acceptable to use. The logo has not been used since. Secondly, it has derogatory comments made about individual SHP staff and the impact on staff morale. The social media report provides no evidence of such comments. The site moderator has been unable to identify such comments, nor has he had complaints from SHP or a site member who is now a SHP board member. The site rules state, be kind and courteous and post a moderator. For the report itself, paragraph 2.2 to 2.3, the CCG collected 127 calls from patients making complaints about the telephone access issues since July 2020. None of these patients were contacted in the review. Paragraph 3.2, this states a review of the SHP website now shows that patients can undertake the following: book an online appointment. This is factually incorrect, as NHSE guidance on the 3rd of March suspended online bookings, and it has not been restored by SHP. Paragraph 4.10 refers to the SHP phone system capacity of 50 callers with an automatic cut-off and an automated message giving the caller their position. On the 3rd of August 2021, patients recorded the automated message was removed the day before without any SHP explanation then or since. Paragraphs 5 to 5.13, only one patient, the interim PPG chair, is cited by the report at length. On the 15th of the 6th, 2021, at an online SHP patients meeting, she was identified as now being an SHP board member and previously has been on the SHP board as a selected patients representative. Given the amount of criticism of SHP by patients and counsellors, why did the CCG seek the views of just one patient so closely involved with SHP? Paragraph 7.1.2 7.2 refers to the difficulties pharmacies had phoning SHP. On the 9th of February 2021, SHP stated it now had a dedicated phone line for healthcare professionals. This did not include local pharmacists. By April to May 2021, via Facebook SHP asked those wanting access to make contact by private message. Surely the local pharmaceutical committee was the way to inform them. Paragraph 9.2, on the 17th of the 5th, 2021, SHP introduced a new phone system with 6 options to reach departments. That day, 25% of all calls were not answered. On the 24th of the 5th, 2021, 39.3% of calls were not answered. A month before, 71% of calls were not answered. Paragraph 11.1. After 5 days of operation, a joint review of the phone system was held. Of 5 days of data and adequate period to reach conclusions. Patient experience still raises severe criticism of the phone system. Paragraph 12.10 refers to breast and bowel screening, which were performed by an NHS body, not SHP. SHP's contractual requirement is to provide 6 to 8 weeks postnatal appointments for mothers. This is not mentioned. I include 2 screening roles not performed by SHP, and this one that is. Paragraph 12.11, COVID vaccination statistics are cited. This is an additional task undertaken by another local GP consortium with SHP, which is separately funded by NHSE. NHSE require this work not to be detrimental to normal GP services. We find the CCG reports is unsatisfactory with a number of factual errors and cites only one patient's views, some of which are factually inaccurate. A more detailed response is being prepared for the CCG. It's the end of the deputation.
Thank you for that, Joseph. And at this point, I'd call on Karen Helliwell to give a response to that. But I think there will be a more detailed written response to follow. So, but I'll call on Karen to respond initially.
Thank you very much, Chair. Hopefully everybody can hear me. Obviously, the CCG takes this issue extremely seriously and has an improvement plan which we monitor every fortnight with the provider. So we do undertake this, and we will make sure that the comments and issues raised in the response are reviewed in detail, and we will provide a response both to the PPG and to yourselves, so that all matters are investigated thoroughly. So that process has already started. So we'll ensure that's done in an extremely timely manner. Thank you, Chair.
Thank you, Karen. And just for everyone else's information, there is a meeting planned between the CCG, SHP and the Monks Path group, and then a separate group, a separate meeting with the administrators of the Facebook page, which I'm going to be involved in as well. So there are various conversations taking place, but there will be a full response to this deputation. So thank you for that. And we'll move on to item 4, which are the minutes of the previous meeting. So if anyone has any amendments, anything that they believe is incorrect, can they let us know? Otherwise, those minutes are there for information. Can't see any hands, so we'll take those as read, and they're fine. Moving on to item 5, we've got David Melbourne has joined us on screen. So David is the ICS finance lead, and he's going to, first of all, for the item 5, give us an update on the integrated care system, and then he does have a separate item, item 6, around finance, but we'll keep those 2 items separate. So can I ask David to present item 5, please?
Thanks, Councillor Grinsell. I hope everybody can hear me. Now, I've looked at the agenda, and I've got a number of my colleagues here today who can actually update on the ICS and the work that we are doing in establishing the ICS for the 1st of April through the agenda. So I don't propose to go through a lot of that, but just to say that the ICS is obviously our health and care system, and I see that as a really important platform to do a number of things. Restore services across Birmingham and Solihull, make sure we've got access to services, make sure that we get vaccinations, address inequality, and make sure that we get the money right. So, Councillor Grinsell, what I wanted to do, and I know some of those areas are on the agenda. So, for example, I've got Richard Kirby with me here in the office, and I think he will probably talk about the inequalities work that we're doing later on in the agenda. I can see Anna Hammond, who will talk about some of the work we're doing on Solihull Together and on Place. So, given the time, I just wondered if we went on to the finance issue, and I know it's something that you particularly have asked us to address. And to do that, I've suggested that the interim ICS CFO, so he is, so that's Paul Athy, who is on the call, actually provide an overview for the Health and Wellbeing Board in terms of how we might allocate money down to place. And obviously there are only 2 places in our ICS, Birmingham and Solihull, and the guidance is very clear that we should have an allocation down to place. Now, that allocation is separate from having a budget, and I think it's that issue that we wanted to walk the committee through, Councillor Grinsell, so we could understand that. And just to say, this is still a developing area, so bear with Paul. He's leading that piece of work for us. Actually, Paul, your chief finance officer is also working on this with us. So without further ado, if that's okay, Councillor Grinsell, I'll hand over to Paul.
Okay, thank you, David.
Right.
I'm going to attempt to share some slides. I've not done this on WebEx before, so hopefully it works. Has that come up? People see those slides? Anyone? Yeah, thank you. There's a whole slide pack in there. I'm not, given the time, I'm not going to suggest to go through each one in detail, but if I could pick out a few of the key points and then happy to take any questions or to discuss at the end. What we were trying to cover today is to give you really a first viewpoint of how place-based finance might work within an integrated care system. So what I'll take you through here is a little bit about where we are now, the work that we've developed so far in terms of working through what a financial framework might look like for Solihull, and then give you a bit of an idea of the work that's still progressing and how we might get to where we want to get to. In terms of overall allocations, we're expecting them to continue in a similar way to the way in which CCGs currently receive NHS funding. So we expect that from 22-23, integrated care systems will receive an overall allocation. That will be ring fenced into a number of pots that we have to ensure that we spend our money on. We expect that we may well have other delegated services passed down to us from NHS England as well, around dental, optometry and pharmacy. However, discussions are still ongoing in regards to that. We expect our allocation will be set based on a new weighted capitation formula that the government are developing, which is intended to take account of the health needs of individual populations. However, it's fair to say that currently, whilst we do have a target allocation as a CCG, our resources are based on historic funding levels, with a pace of change adjustment that takes us from the current funding levels to our target allocation. And it's likely that that will continue as we move into becoming an ICS. If I skip through that one, just to give you an idea of where we're starting from, we're currently in a position where we're breaking even for 21-22. So financially, we're in a reasonable position as a health system for 21-22. And usually this year we've been set our allocations in two halves. So we've received our allocation for the first half of this year and are awaiting an allocation for the second half starting from the 1st of October. We do expect that whilst there will be some additional efficiency asks of us in the second half of the year, overall that's still quite a positive financial settlement, and we do expect to therefore be entering the ICS in a break-even balanced financial position. What that doesn't take into account, though, is the underlying financial position of the system. So as you'll be aware, during 2021 and 21-22, we've been in receipt of significant amounts of additional non-recurrent funding to support us during the COVID pandemic. And you'll be aware that additional resources have been announced by the government for 3 years from 22-23 to continue to support the recovery post-pandemic. However, taking those non-recurrent resources out, we do carry quite a significant underlying deficit across the health system, which we estimate to be around about 180 million. Now, as I say, that doesn't account for any additional funding we're expecting to receive over the next 3 years, but it does hopefully give you an indication that there are still financial challenges that we will need to manage through our health and care system over the next few years. We're developing a financial strategy and a roadmap around sustainability to help to bring that position back into financial balance as that non-recurrent funding starts to tail away over the next few years. And that will be a topic for conversation, I'm sure, as we go through the first few years of the ICS. Now, clearly, the main purpose of this session is to help you to understand what that financial framework might look like for Solihull Place. And we were asked to share some numbers with you to give you a bit of an indication as to where that baseline might start from. We are still developing that piece of work. Since BSOL CCG was formed in 2018, we haven't described or split our budgets or our accounts down at a place level. So this is a new task for us to deliver. The slide there does give you some indication of the overall likely envelope of resources. The last time that we had Solihull CCG accounts, they showed a revenue allocation of 333 million and expenditure of 340 million. So that gives you a sort of ballpark figure, with obviously inflation and service changes since then of the sort of resources we're likely to be talking about for Solihull Place. As I mentioned, we need to work through how we're going to set allocations down to place, and our overriding principle in all of this is to ensure that we aren't doing anything that would destabilise current services as we move to our new regime. So whilst there are a number of ways in which we can look at how allocations should be set, and we would certainly want to pay attention to a needs-based formula to look at how money should be allocated across Birmingham and Solihull, it's likely that for the start of 22-23 at least, we'll be looking to base our budgets and our allocations on current spend, as I say, so that we don't do anything that could destabilise current service provision. That's not to say that over a period of time following that, we would want to understand how we could move from current spend levels to something that more reflects the needs of our population. But obviously that would be done in consultation with all our partners across the system. Probably the main thing that we need to work through when we're developing our financial framework is how the various resources are moved around the system and how that delegated responsibility works within the system. And this slide is just intended to give an indication of how each part of the system, and in this instance Solihull Place, will interact with that financial framework. So we expect that there will be a set of resources that are controlled by each part of the system. It's likely that as we move into the start of our ICS from the 1st of April next year, again looking to ensure that we don't destabilise parts of the system, that won't change significantly from the model of service and the model of contracting that we currently have in place now. But over time, we'd be looking to delegate more responsibility and control for the budgets that we have in place, having the ICS out from the central body of the ICS out into each of the different component parts. Probably the key part, I think, to our financial framework, certainly in 22-23, will be how we work with each of those parts of the system to influence the element of spend that are relevant to themselves. And we give an example on the slide there around out of hospital urgent care services, which we may well choose to contract in a reasonably traditional way with our urgent care providers. However, as we develop that model, we would need to understand how we work with Place, both in Birmingham and Solihull, to ensure that Place have an opportunity to influence the way in which those services are provided and to ensure effective delivery at a local level. One of the other real key principles as we move to setting Place allocations and budgets is a level of transparency, so that Solihull can understand exactly the level of resources that are consumed by Solihull residents. There may well therefore be services that we're unlikely to look to shape significantly differently in each individual place, but it will be important to understand that the overall level of resources that are consumed. So as an example, we give here around specialist services that are set up by our specialist providers, but we'll be looking to be able to report on the overall level of spend down to a place level. I'll skip through most of these and just finish on next steps, and then, as I say, happy to take some questions. So as you'll see, this is an evolving piece of work. We have a number of work streams that are set up as part of the ICS to deliver this, and we have representation from each part of our ICS on those working groups. So as an example, there is a finance working group that's working through the mechanics of how we set financial allocations, and there is a representative from the finance team of Solihull Council on that group. In terms of timelines, we're hopeful that we will have a first cut of our 22-23 budgets in October 2021. At the moment, we're working on looking at the way in which resources have been allocated historically by commissioners to split that level of that budget out. It's likely that as we move to the start of next year, we're going to want to understand a lot more about how costs are being incurred. and it's particularly given the uncertainty that we've had in the service models, or the variability we've had in the service models over the last couple of years. It may well be that actual spend is different to the way in which we've traditionally commissioned for services. So we're going to need to work through that so that we have a robust starting point from the 1st of April. And as noted on the slide, there are a number of milestones for us to reach there. We're also undertaking a piece of work with Jenny Wood and her team to start to identify where there might be specific service areas in Solihull that we might want to place an early place-based focus on, and start to look at where we may have more defined resources that we can work together to deliver better value from. And there's a piece of work that we're kicking off in October to start doing that. And we're also expecting the publication of some further guidance from NHSEI, and particularly a place-based allocation tool that we hope will be really helpful in understanding exactly what we are currently spending and comparing that against some benchmarking levels, to give us a bit of an idea of where we might be over-committing or under-committing resources, which again might help with some of the prioritisation process as we move forward as a new system. So I think I can leave it there, and I'll try and put the slides down. Happy to take any questions.
Thank you, Paul. Okay, so obviously this is a big area. You know, finance is really important. There's still a lot of guidelines and certainly a lot of work to be done, and you're waiting for some of those guidelines still to come through. I mean, obviously we're living in a pandemic world, and we started looking, you know, we look at the cost, and you mentioned some costs there, a pre-pandemic world. So we don't really quite know yet what that sort of new sort of settled world looks like. So when do you anticipate that real timeline for determining the place level budget around current, you know, what that current expenditure will be? Because you mentioned the deficit. So how will that part of the problem get sorted? And so when will we truly know what our budget and our allocation will be, so that we can provide that transparency and determine what outcomes we want? Yeah. And, you know, what that a new activity looks like.
So obviously we're working back from the 1st of April 22 as the point where we need to make sure that we've got those budgets and allocations in place. We expect, as I said, there are probably two key milestones between now and then. We're doing a piece of work with our providers to understand their overall provider cost base, which we're anticipating finishing by January 22. So at that point, that should give us an idea based on current cost, what we're spending in each part of our system, and we'll be able to share those numbers with you. At around about the same sort of time, we'd expect to receive an overall allocation figure for the system for 22-23. That tends to come out January, February time. And then there'll be a piece of work that takes that baseline position forward, looking at the additional growth funding that we're expecting to receive to deliver a number of the health priorities that are set out for the next 3 years. So that we'll then have a process between January and March where we move our sort of historic baseline level of funding up to what we expect to set as a start point for 22-23. Clearly, that's the same sort of time period that we're working with you to set some of our priorities in terms of planning for the next year as well. So hopefully that should dovetail nicely together.
Lovely. So members, do you have any questions? Got Tim Brown, and then I've got Councillor Sexton.
Thank you, Councillor Grinsell. Just an observation, really. I suppose what I'm very mindful of is making sure that our joint commissioning arrangements between the council and across children's services and across to the ICS arrangements are really robust, so that we are commissioning the right services at the right time in the right way. So it'd be useful to have that as an item that we revisit periodically, I think, as part of the developments.
Paul will take that on board.
Yeah, absolutely.
Councillor Sexton.
Thank you, Chair. I've got a couple of quick questions. I mean, the first one is, in terms of just an overall, in a nutshell, how does this new system of financing differ from the old one? Are there any key points you can make? Because I know we've heard a lot about the finance of these ICSs. I'm just trying to get an overall sense of what the main differences are here.
Okay, I think there's probably two main differences. The first one is that there is now a collective responsibility on all health partners within the system to deliver a financial balance across the health system, which therefore hopefully starts to break down some of the challenges that we would historically have, where we possibly would make decisions in the best interests of individual parts of the system as opposed to in the best interests of the overall system and obviously the patients and citizens who live within that system. So I think that's probably the most fundamental difference. Where that leads us to is, whilst the allocations will be given out on a system level, the system has the opportunity to delegate those responsibilities for the way in which we're going to work down to individual parts of the system in a way that we haven't done before. So historically, individual trusts or individual providers would only have the responsibility to deliver their statutory duties as an individual organisation. The ICS has the opportunity to delegate down to individual providers, to care programmes, or to place the responsibility for delivering services and assuring ourselves on the effective use of resources down to those individual parts of the system. So over a period of time, as the system develops in its maturity, it could well be the case that resources are delegated down to Solihull Place, for example, and the responsibility for utilising those resources and the flexibility to utilise those resources would be delegated down with it.
That's very helpful, thank you. In terms of working out the current spend for Solihull, can you say a little bit more about how that will be done? For example, in the case of hospital services, where Solihull patients are treated in Birmingham hospitals, are we working that out on the basis of per patient or by the service? Or, I mean, if you can give us some ideas around that. Yes, and I have a follow-up as well.
Okay, so yes, so we're looking at, as much as possible, trying to build everything up from a patient level upwards. So there's a significant amount of activity information that we get from general practice and from hospitals around what happens to our patients at an individual patient level. And there are currently national tariffs, and hospitals will have their own costing mechanisms that allocate costs out to individual patients that enable us to build up from what's actually happening from an activity point of view and apply a cost to that. So that's the approach that we're working through at the moment. And in most cases, we think that we've got activity information that enables us to get a very granular view of the costs at a place level. There'll be some services, particularly community and mental health services, where the activity collection mechanisms haven't necessarily been developed over time in the way that they have within the acute setting, and we might need to look at alternative methodologies for doing that. And it may well be the case that for some services we have to apply some sort of a capitation kind of approach to the way in which resources are allocated. But as much as possible, we're hopeful to do that on an actual patient by patient basis.
Okay, that's great. And you talk about moving from the current spend to a targeted spend. When that happens, are we expecting the allocation for Solihull to go up or to go down?
That's the question that I wanted to get an answer to, and we aren't quite at a point there. So, but I think what we would be looking to do is to understand through the allocation tool that I described what a needs-based allocation would be for a system, and compare that to what we're currently spending. Now, when we are very unlikely to be able to move in any sort of speed from the historic allocation to a needs-based formula without destabilising services, and we've got no interest in destabilising services. What we might look to do, though, is through the way in which resources are prioritised in the future, understand where there are areas of particular need, which might be a geographical area, or it might be particular services that we're shown to be investing lower than other parts of the country. And that might form part of the way in which we make prioritised investment decisions in the future. But I think it's very unlikely we'd be looking to pull resources out of one part of the system and move them to another part of the system simply to try and sort of match up to a notional allocation. I think that would bring more challenges than it would bring benefits.
Okay, well, we'll look forward to hearing more about that. Thank you very much.
Are there any more questions in the audience? Okay, so Paul, when are you proposing to bring back sort of your next stage of work?
Given that Councillor Sexton's last question, which I think is a particularly pertinent question, it would be helpful next time to come back with some actual developed numbers so that we can sort of work through some of those challenges in real terms. So I think probably something around about January time would be good, so that we've actually got some numbers that we can share with you, and we can build that into the way in which the planning process might work for 22-23 as well.
Okay, you were breaking up a little bit there, Paul. So yes, I gathered that you'll be bringing back further reports in January for us. Okay, I think we're breaking up. Okay, so thank you for that. I know there's a lot of work going on with officers at the moment, and I say you've mentioned our finance officers. So I think those there'll be a lot of conversations in the interim as to. Thank you for the report. I'm going to pull an agenda item forward, and that's the item 8. The ICS Inequalities Work Programme, because I know Richard Kirby is only with us for a short time. So Richard, can I ask you to bring your item forward, please?
Thank you very much, Councillor Grinstall, and thank you for the invitation to talk to you briefly about the work that the integrated care system is doing on inequalities. And I guess at the start of this, I should just say a thank you to Ruth for her contribution to this work alongside Justin as the Director of Public Health in Birmingham. We've included a written update on the work in the papers. There are just 3 quick things I'd like to pull out. First is, I think last time I spoke to you about the Inequalities Work Programme, we were only right at the start of working out what it was across the ICS that we needed to focus on. And we've moved from sort of 3 big priorities, making sure we're doing all we can to tackle inequalities, making sure inequalities are at the heart of the ICS, making sure the NHS is playing its role as an anchor institution across the system, to 8 areas we will be working on now together across Birmingham and Solihull as a system. And those are on page 32, I think, of the pack that you've got, so I won't rehearse them one by one. They do affect Birmingham and Solihull differently, and they have a different focus in different areas. So some of the work around early years in Birmingham is very focused on infant mortality. In Solihull, we will support the existing Solihull Together work around the first 1,000 days of life through this work. So we're much clearer now what we're seeking to do. There's a lot of existing work, particularly around the COVID-19 vaccination uptake and COVID-19 elective recovery and long COVID pathways, to make sure that the work we're doing in those areas is helping the people who need it most first, and not widening existing inequalities in access between different groups. And some of the work we've done so far, particularly on elective recovery, suggests we're managing to do that fairly and consistently. And then I think looking forward, the 2 big bits of work we will pick up next is the system-wide work on prevention and management of long-term conditions, and we're working really closely with both Ruth and Justin on that. But diabetes is likely to be an early priority, as is coronary heart disease and respiratory in that. And secondly, then the work on anchor institutions and the role particularly that the NHS employers play in the places they operate from and where they spend money and where they employ people, to make sure that we're doing everything we can to help tackle some of those long-standing issues in some parts of Solihull and some parts of Birmingham that exist. So that's, I think, where we are. We've got a clear sense of the kind of 8 things we're working on. There's a lot of work in the here and now around the COVID-19 response and recovery and inequality. And then we're looking next at prevention and the role of the NHS in particular as an anchor institution. Bearing in mind, I think that's something local authorities have traditionally been very clear about and are much further ahead in terms of understanding their role than perhaps the NHS is, which is why the NHS focus is there. So I'll leave it there, Councillor Grinstall, as an overview. I'm really happy to take questions or comments, or it may be that Ruth wants to add something as well. Thank you for your time.
For the report, Richard. Great report. The only thing I would stress and would ask in future, when I read the report, I do feel sometimes it's a little bit more Birmingham focus. I know we're working right across the system, but I know you've mentioned certain areas of work and demonstrate, the work that you're doing with Wash with Teeth, PCM, for instance, around long-term conditions. I suppose I'd really like to see how that translates here to Solihull. I know that might be a pilot, but then how we pick up that work here and what is being done here. And I know just verbally mentioned some of those. So it would be great sort of in future reports, sort of demonstrating a bit more of that work here in Solihull. I know other colleagues might want to bring other things in. I'm very keen to hear what you around the local recruitment, because we do talk a lot around local jobs for local people. And clearly, there's a lot of health jobs, there's a lot of social care jobs out there. So it's how we can match people to those jobs. So I'll be interested to hear more about that. But also as well, the community engagement. You've mentioned that in the paper, and just where we are on community engagement around health inequalities.
Yeah, so I mean, firstly, my apologies if the report feels a bit Birmingham facing. There is some North Solihull work that's linked to the Washwood Heath work that, and we can certainly produce I mean, we've shared the same report with both health and wellbeing boards in this cycle. So if a more kind of 2 more tailored ones work better next time around, I'm really happy to do that. On the local recruitment point, I think it's about kind of 2 things. So it's something about the kind of jobs we are advertising and making sure that particularly the roles that people might take as a first job in, say, the NHS, for instance, are properly accessible to people who may not have had traditionally the kind of opportunities to get what, after all, are relatively well-paid, relatively stable public sector jobs. So actually, UHB from their hub at the Queen Elizabeth have done quite a bit of this work over the years. And what I think we're looking to do with the People Board in the integrated care system is extend that significantly. So we work with people who might want to join us to make sure they've got the kind of skills and kind of opportunities that they need to do well, so that we can then bring them on board, particularly through apprenticeships. And I think we've got an initial ambition that's relatively small scale to prove that works, and then as it grows, it will grow. So I'd be really happy to again share more about that in future meetings as we go. On the community engagement side, we had a first discussion at our last board meeting, which was really kind of thought-provoking about how to engage properly with communities. And some folks from organisations like Citizens UK and some of the other organisations in Birmingham and Solihull that work in that space joined us. And as a result, we've got a small group doing some work for us on what the best model, particularly for system level community engagement, should be. Because of course, a lot of community engagement has to happen at the neighbourhood, through the primary care network, through the kind of local on the ground structures, and it won't work from a sort of system office somewhere for the whole patch. So we are just working through where as a system we add value to that community engagement process. And it's probably by getting alongside the primary care networks and helping them fit really well into existing local networks and local communities and be properly plugged in that I think we're going to look at in the first instance. So hopefully that helps with those questions, Councillor Grinsell.
That's great, Richard. That's great, Richard. Thank you. Yeah, and obviously we've got lots of trusted local voluntary and community organisations within Solihull that it would be good and probably key for us for you to connect with those, and how we work with the network of voluntary organisations that are out there. I think someone's put in the chat something about digital. Did I see it? I saw digital pop up. Likewise, how the digital programme will impact Solihull would be helpful. So that's a whole separate piece of work, isn't it? That's going on about digital inclusion.
It is, and I mean, all the NHS providers are increasingly using remote consultation and digital forms of delivery. What we've got in train is some work to make sure that isn't disadvantaging particular groups, whether that's low income families or older people who may in some instances find it harder to connect. So we've got that review underway, and again, really happy to share what comes out of that work at the right point.
Okay, lovely. I think I can see Councillor Sexton on the screen with her hand up, and then if anybody else would like to indicate while we've got Richard with us.
Thank you very much, Chair. Yes, I'd just like to second what Councillor Grinsell said about the Solihull focus. I mean, we know that within Solihull we do have some really significant health inequality differences if we compare different wards in the borough, for example. So I'd be keen to look at how any plan is going to impact Solihull, as well as the differences between Solihull and Birmingham, obviously. Can I just ask when we expect to have the outcomes framework, and whether there'll be an opportunity to look at that and to comment on the framework itself?
Yeah, so we've got a draft of that we're working on at the moment. I'd be really happy to share it, now, and frankly, the more comments we get as we build it, the better. So if kind of through officers I can share that, I'm really happy to do that after we've finished this meeting. Fantastic.
I'd really welcome that opportunity. In terms of the engagement, you mentioned in the risk analysis that the engagement work stream is due to address this during the first half of 21-22. I mean, as we're now coming towards the end of that first half, I'm wondering sort of how far that's progressed and how that's going to develop going forward.
So I think, as I said, the challenge for us is to find what it is that the system level engagement adds to the really strong local community engagement that exists already, and that's partly what the Washwood Heath pilot, and there is also some parallel work with one of the North Solihull PCNs taking place at the same time, is designed to test. I think so we're probably 2 or 3 months behind where we thought we'd be when we set the original plan. But I think the key is going to be that we've got to help the primary care networks across Solihull in this context fit into those existing local networks that Councillor Grinsell was talking about, and that you will have as well, rather than attempting to build a parallel or rival structure in some shape or form.
Excellent. And I mean, as we heard earlier on, we know that some of the primary care networks in particular in Solihull are having some difficulties in patient communication, shall we say, or patients are struggling to maybe get hold of their primary care networks. How can we be sure that those particular patients' views are not being neglected in this consultation and in this arrangement? Because I know people, for example, who've said that they've stopped trying to contact their doctor because they just can't get through. So those are particularly the people that we really need to be talking to.
Yes, and I mean, Karen at the start of the meeting responded to the particular point about the kind of example you gave, and I think there's something then about the inequalities work and the model we're building for primary care network community engagement and the CCG's work on primary care development just fitting together in the next month or two, so that we are as clear as we can be that each primary care network has got the right range of contacts and is hearing the right range of voices. But it is, I mean, it's one of those things you've got to be kind of permanently working on. I think it's not a thing you do once and then it's finished. So certainly in the work we've done so far, we've tried to look hard at who we're hearing from and who we're not hearing from, and to be very conscious of that. But we'll keep going at that, Councillor Sexton.
Absolutely, and yes, I'm just very conscious that it's there are maybe some hidden voices there, and there again, you know, it's some groups in particular who are struggling with the more remote style of consultations now, and we're hearing from some of them as well. So maybe I can we can talk offline out of this meeting, and I can give you some of the feedback that I'm hearing there as well. And then finally, my last point was around anchor institutions. I think very often it's easy to make this connection that, you know, employment leads to better financial outcomes, leads to better, less health inequality. But I think one of the missing things there is actually the quality of that employment is really important, and levels of stress with that employment, again, also have an effect on health inequalities. So getting people into jobs is not necessarily going to reduce health inequality if those jobs are highly stressful, for example, and lead to high levels of burnout. So what I'm thinking about is, as well as looking at numbers of jobs, are we also looking at, for example, how those jobs are affecting people? I mean, we're hearing about high levels of stress and burnout from some of our NHS colleagues. For example, I've heard some stories about this. Is that something that we're also addressing alongside the point about getting more people into jobs?
I mean, it's a good point, isn't it? And I guess part of the reason why the NHS I think is so important is probably typically NHS jobs are relatively high quality jobs, in the sense they are, you know, relatively stable. They bring a public sector pension, and so I think they contribute in the way you're describing. I mean, all of the NHS organisations in the system are working really hard to make sure we support our colleagues to be healthy in their jobs, particularly in the context of what everybody has just been through. And it's not directly my piece of work, but there is some work going on within the integrated care system led by Rasheen Fallon-Williams and the People Board around health and wellbeing support for NHS staff and helping people who may be facing the kind of stresses you describe. So it's not directly my field, but we have got work going on there to try to tackle that.
Great, thank you. Thanks for that.
I think we've got James Waller.
Yeah, I hope you won't mind me sort of coming back to and reiterating a point, but I think it's really important. It comes back to the digital inclusion part of this. There is a little bit in the report about digital inclusion, but I think we've seen, as Councillor Sexton pointed out from right at the beginning of this meeting, we've seen that there are a lot of people who are really struggling with what has become an almost exclusively digital access NHS over the past little while. I know we're getting some of that back, but people in Solihull's experience is that, particularly in respect of primary care, their access to primary care is only digital for a lot of people. And one of the problems we've got from a health inequalities point of view is that the people that struggle to access anything digitally are people who are already very significantly affected by a number of health inequalities. They are older people, they are people with cognitive impairments, they are people with significant mental health challenges. And this is not a concern or a worry or something you need to keep an eye on. It's something that is happening now, every day. There are people who are going to the community advice hubs and asking hub advisors to call their GP for them because they can't get through and they don't know what to do. So I think this digital inclusion point is really, 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 really important. Those people people have probably heard me talk about this 3 or 4 times at these meetings in various ways at times, but I just think it's because it's actually really important. And the closer we get down the route of making things digital by default or digital by design or digital by any other thing that we choose to name them, we're getting further and further away from health equality for some people. And it's not a potential issue or something to look at, it's happening now.
I mean, I think it's helpful to have that reinforced. We've got the work we've got in train is tracking who is using digital services and who isn't. And so we should have quite soon the kind of data to back up the point you're making there, and then that will enable us, I think, to start working through what the right model needs to be, because it will need to be a mix of models going forward, and we'll need to work out how to help those groups who find accessing a particular model harder. So that's the bit of work that's in train, and we should, I say, quite soon be able to come and share some more about that with you.
Yeah, I should also point out that we have sorry, we got bounced back here. We've got a programme with Age UK around our digital pilot. So there is work going on to try and encourage more people to get online, but clearly we must not exclude those that can't or just aren't able for whatever reason. So I think Richard has taken that up, exactly what you've taken on board. He's taken on board exactly what James has said. So yeah. So thank you, Richard. I think we need to let you go now, don't we? But we look forward to receiving further papers from you, and we will plan those into our agenda setting. So thank you for coming here this afternoon, and I think the board does appreciate all the work that you're doing around inequality. So thank you.
Thank you very much. Thank you for your time.
See you soon. Thank you. Okay. Ruth's going to give us her COVID update next. And whilst Ruth is doing that, a few of us are going to move to the chamber so that we can conduct the meeting slightly better, we hope. So we will go off screen and Ruth will hold the fort. So I'll see you in a minute.
Thank you, Chair. So can people hear me on the screen? Yes, I'm getting some thumbs up. Yeah. So just usually like we've done for quite some time at the board. We're moving into what's clearly a very different phase with COVID. So at the moment, the key issue is, as we talked about at the last meeting, is what's the impact of COVID going to feel like going into winter? So current position is that our rates have increased slightly as a result of the schools going back. So we're now seeing a rate today of 375 per 100,000. And what we are seeing is continued high rates in the 11 to 16-year-old group, which has been accelerated as a result of schools going back. So continuing, I know Louise, who's our head teacher rep on the board, will be well aware of this, to see quite a lot of spread going on within schools. Obviously, we are seeing the rollout of the 12 to 15 vaccination programme, which in time should help reduce those rates. That is starting to be rolled out locally over the next week or so. Really important that we cut through some of the messaging out there from some of the anti-vaccination campaigners and really get the message across to parents, teachers and children themselves that this is about informed consent. So really important part of the vaccination programme to move through to that next age group. The other thing that also has started is the booster programme, which was announced by JCVI. So again, we're now starting to see the most vulnerable people in our communities going through that kind of the top-up booster programme. So we continue to have good uptake of vaccination locally, but again, we continue to work on those areas where we are continuing to see lower uptake and people who haven't had the first or second dose, because what we are concerned about going into the winter, that as we get more people socialising indoors, more people congregating, that actually that could translate into an increase in COVID rates during that winter period. So really keen to get the message across that actually continuing to test regularly, wear masks, take care, particularly in indoor settings, is really, really important. And for anyone who hasn't had that COVID vaccination, getting across the message it's never too late to have that, and really important that people do that. So just going back on to the impact on the NHS at the moment. So although we obviously have seen a reduction in the number of people requiring hospitalisation and intensive care as a result of the vaccination programme, we do continue to see relatively high numbers of people who are going into hospital and are needing intensive care. So running at about 25 people in intensive care with COVID. So, it still continues to place quite a significant pressure on the NHS. And obviously that is something that we would collectively be concerned about going into winter. In terms of the local response, so what we're continuing to do is to say, well, what needs to look different going over the winter period? So really shoring up defences as we start to deal with other bugs that are in the system. So we know at the moment that we've got quite high levels of respiratory virus affecting children. So that is beginning to put pressure on the system as well. Flu is showing very early signs of starting to circulate. So again, really important that people get the message out about flu vaccination. And again, we get good take up of that this year. And then really planning for how we can do everything we can around some of our potentially more vulnerable sectors going into winter. So making sure that there is good protection around care homes, for example, as we go into that winter period. So that work continues to be led locally by our multi-agency local outbreak management boards, and we're continuing to refine those plans as we go into the winter. The other thing, really, just to point out, obviously, we continue to see the Delta variant being the dominant variant out there. It does continue to spread quickly in unvaccinated communities, but so far we're seeing very little in the way of other new variant activities. But obviously that's something that, again, we continue to watch out for, anything where we need a very rapid local response if we see any signs of that coming through. So I think those are the key headlines on COVID, but again, very happy to take any questions if anybody's got them.
Thanks, Ruth. Has anybody got any questions for Ruth at this point? No, I think we're okay. So thank you for that, and we'll proceed to item 9, the Ofsted visit. So I think, Tim, you're going to present the findings of the Ofsted visit. I know at a previous meeting, I think it was mentioned briefly, but over to you.
Thank you, Councillor Grinsill. So as members will be aware, we received a focus Ofsted inspection in June, and that was primarily to look at arrangements for the protection of children from extra-familial risk. And as you see from the paper, the report was very positive about the services, and I think it's important we recognise the tremendous work our social work teams are doing, particularly despite the pressures of COVID. But essentially, the key finding was that vulnerable children in the borough are cared about and protected from harm and risk well. The approach to exploitation reduces the risk to most vulnerable children and young people, but the response to children going missing needs to be improved. And it also recognises that leaders have been very creative and proactive in ensuring that children receive the right support at the right time. I think, as with all inspections, you do expect to get areas of development. And for me, the main issues are really around the caseloads of social workers to make sure that they don't have excessive caseloads, the pressures on MASH and timeliness of referral are timely, and to make sure we have whole system ownership of across the Children's Partnership, and including my previous comment about linking to our joint commissioning arrangements. But I'm very happy to answer any questions members may have.
Members, any questions? No, it wasn't a graded inspection, but it was a very positive outcome, wasn't it? So I hope that stands us in good stead, Tim, for future inspections. Hopefully those are not too soon, because Ofsted always put the fear into people, don't they, when you mention them. And I can see Louise is nodding her head there. So thank you for that. I don't see any questions. So comprehensive report on the findings there. Just while I've got, and I mentioned Louise, is there anything sorry I didn't ask you on the last item, if there's anything that you particularly wanted to highlight about the return of children to school?
Not especially. It's been quite a normal kind of start, I think. I'm pleased to say it's been lovely to have assemblies back and the things that we usually do that we've kind of forgotten in the last 18 months. But I do think, you know, clearly COVID is not over, and we're still getting or having lots of precautions put into place with hand washing, ventilation, increasing numbers of children and staff off in schools, and that's having a massive impact and will continue to have a massive impact on budgets. For those of us who've got staff going on maternity leave, all of that is obviously brought forward to 28 weeks. That causes budgetary issues as well. So great on, you know, for some things, not so great, and a bit like last year for other things.
Thanks, Louise, and thank you for all you're doing to get all our children back to school. I'm sure they're all very excited to be back with their friends, so back to learning as normal a routine as possible.
Thank you.
Okay, so we're going to move on to item 10, which is Solihull Health and Wellbeing Strategy Scorecard. And I think we're back to Ruth on that one. So over to you, Ruth.
Yeah, thanks very much, Chair. So I think this really ties into the next item we've got on the update from Solihull Together, where there's more information about the outcomes framework that's being developed. So what we've got here is very much the kind of routine monitoring of the current health and wellbeing strategy indicators, and what you can see here certainly in certain service areas, and I know Rob Davis is going to come in a minute on this, is the COVID impact that we are managing through on a number of our services. So quite a few areas where you know, we have seen some of the disruption to services, or just generally actually societal disruption that is showing through. So particularly around some of the childhood, those important early years outcomes. We are seeing that through, so really important that we can look at what plans we can put in place around some of the recovery of those services. So just as a reminder for people with the scorecard, most of the measures in here will be overseen by different boards. So for example, Ageing Well is looking at some of the outcomes relating to older adults. We have a section on COVID, which is overseen by the Local Outbreak Management Board. But I think the idea is always that we come back to the Health and Wellbeing Board regularly with an overview of all those key indicators. I think the next stage is around this, and again, colleagues from Solihull Together may want to come in on this, is really to start thinking about, as we move towards the kind of outcomes framework for Solihull within the ICS, how we pick up some of those measures as part of that work. So this is very much a kind of staging post as we get to that point. But I'll bring in Rob, because I think if he's on the line, there are some specific areas that he was wanting to cover for the board.
Thanks, Ruth. Can everyone hear me okay? I realise we had a few issues. I'm having a few thumbs up, so brilliant. So the report is in your pack from page 49 onwards. As Ruth said, I'll kind of give an overview of some of the key impacts, and then I'll delve specifically into one of the ones that's shifted most, which is development and communication in our 2-year-olds, our pandemic toddlers. We're starting to see a bit of an impact there. And I'll talk through a few mitigating measures just to highlight to the board. So overall, for priority 1, we have seen a significant drop in communication and overall development in our 2-year-olds, and we're expecting to see that again in our 4-year-olds. We are rapidly scoping out catch-up programs for those with delayed developments to get them back up to speed, so that doesn't become an issue of cumulative life course difficulties. In terms of our second priority, which is adulthood and work, we've slightly tweaked the scorecard here to be more in line with what's reported to the Employment and Skills Board. So there's more accountability there than previous iterations. It now focuses more on how we're engaging people in education and training and employment programs, and placing people in training and/or jobs. At the moment, they are under target. Well, overall they are under target, but there's significant overachievement on some areas, balanced out by significant underachievement on others. So there's mitigations in place that we can see in your pack for that, but overall there's still work to be done on the workplace priorities. In terms of priority 3, which is the ageing well and later life, We have seen an uptick in hip fractures and hospital admissions due to falls this quarter, and we continue to see very few health checks because the primary care system at the moment is clearly not prioritising those for understandable reasons. So they remain significantly under what we would expect in non-COVID times. There aren't any specific updates this quarter for priority 4, which is social connectedness. Those indicators are more annual or biannual. And priority 5 is around the COVID impact. Ruth mentioned that overall our COVID vaccination rates in Solihull are favourable when compared to England, but we have specific inequalities groups set up in the recognition that that covers over a lot of variation within Solihull, particularly low uptake in our Northern Regeneration boroughs. And even we're at the point where we've got output areas, so 50 to 100 households, we can zoom in on where our very low uptake areas, and we're trying to get plans in place to re-engage and improve access to vaccinations in those communities that are further behind on vaccine uptake. So just to highlight the issue I mentioned before around our 2-year-olds, just very briefly. So previously, we have a target of 92% of our 2-year-olds to achieve an expected level of child development, and we're currently showing 80%, and that whereas previously we're around 86 to 87. So that is the biggest drop we've seen in about 10 years. So I wanted to bring specific attention on that and just put a few points on what our plan of attack is there. So in theory, these are the pandemic toddlers. So they are the ones who have been at key developmental stages, have been in lockdown and or not able to go to infant or nursery groups. And we think this is showing through in specific communication delays and their overall development in a specific cohort. And we are designing a booster program to enable them to catch up between 2 and 4, which is their next assessment of similar child development. So we're currently sharing information with our health visiting team who commissioned that check to identify exactly who these families and children are, and we're able to do that. So they are on our radar, we know who they are, in order to offer them something new, different, or a catch-up program. So our current mix of interventions, I won't go through them all, but it's a mix of face-to-face parenting courses, online parenting courses, resources they can access from libraries in terms of bonding with childhood, encouraging reading, both with parent and child, but also in a group, and support with specific home learning where that is still necessary. And we've set up a program where we will be able to implement these with those targeted people who we've identified as behind, and we're going to check them both before and after these interventions with standardized questionnaires to see if that has a significant impact. So in theory, we have a catch-up program, we'll have the baseline of where they are, and we will be able to monitor the impact of that booster program and where they are relative to the rest of the pack. So we just wanted to highlight that as one of the most significant changes from last quarter and one of our main mitigating measures. So I'll pause there and invite questions on that or any other part of the scorecard. And just to reiterate what Ruth said as well, this is kind of multi-agency scorecard. If I can't answer it on the spot, I'm happy to take it back to the relevant board or partner who will be able to fill in more of the details. Thank you, Chair.
Thanks, Rob, and thanks for the update. I think you've picked exactly the one that I was going to question you on, and answered some of those questions about whether what's being done and how, if those children will definitely be able to catch up with the interventions that we're putting in place, and if there's more that needs to be done, you'll be able to identify those. So I think you've answered that very well. I just, as you were talking through around the falls, have we identified where those falls are happening? I'm assuming that more will be probably in people's homes, but is that the case?
I don't know the specifics of that, but we are following up with the indicator owner. I think they are under the impression that that is part of normal fluctuation rather than a significant trend. I can certainly delve deeper on that if there's any specifics around.
Yeah, and I'm just thinking that we can, with a new policy, particularly around minor adaptations, it might be something we can link it to help people get minor adaptations in their home.
Certainly
If
keep that
needed,
back
if
in if that is the
necessary, if
case.
needed, yeah,
Thank you,
okay.
Chair.
The other point I wanted to make was just around, there's quite a few question marks in the report on certain measures and targets, well, on the targets for each measure. So just really how those are being developed, the targets where there are particular question marks.
Yeah, thank you, Chair. So for some measures, we've had long-standing targets that are in there. For others, where we have new indicators, we're still developing some baseline years. So some of them will be first reporting this year, so we'll have a question mark until the end of the year. Some of the other ones, for example, some of the ageing well ones, they're coming online next quarter. And for some of the NHS ones, we've had a bit of a long-term issue setting targets because various different services changed through COVID. We're still working with indicator owners on some of them. But I think 80% are on track, 20% remain sticky issues, and we're still trying to bottom out those issues, if I'm honest, Chair.
Okay, thanks, Rob. And I think the work you indicated, particularly around the early years and the first time.
Apologies if I've lost the chair, if anyone else.
I'm sure, yeah, but we'll make sure it's there on the agenda. And I'm just going to bring Jenny Wood in now because I know she's indicated.
Thank you, Chair. So on work right now as we go into the transition really to full ICS arrangements between the Solihull Ageing Well group and the Birmingham and Solihull Ageing Well board. So they are of interest at both levels, but we'll need to think through for the longer term which group sort of maintains overall accountability and focus for those. But we thought in the meantime it was appropriate that they continue to come here for that transparency, which is why we've got that situation. In terms of your question on falls, the other element that I wanted to add was that through Solihull Ageing Well Board, we've reinstigated the falls group, the multi-agency falls group, to respond to some of the challenges that has been picked out today and that we were seeing anyway as a result of COVID. So that will hopefully start to address some of the things that we're
Oh gosh, there's quite a few hands, I think. Councillor Sexton, first of all.
Thank you, Chair. Yes, and thank you for the scorecard. There's just a few very quick questions. I mean, there's obviously quite a lot of red and amber on the scorecard. I'm assuming that a lot of that is to do with the recovery from COVID and with things like the employment support and things like that. The one that I was wondering about, we've got a couple of questions here relating to mental health. That seems to only be measured with the annual survey. Do we have any measures of mental health that are that we're tracking a bit more tightly on a quarterly basis?
Take that one. So yeah, the priority fall is about the social connectedness one, which is tied to our local survey. In terms of mental health services, we've got weekly reporting on access to mental health phone lines. and various different other services across the piece. And they're going to various different other boards. I guess why they're not here now is because this is very tightly linked to obviously our health and wellbeing priorities, but I can assure you that those other elements of specifically service use of mental health services is feeding back either through contracting between council and NHS or directly from NHS phone lines, etc.
I'm wondering whether it would be useful to have some measure of mental health on the scorecard at some point. I mean, I know that that's not the point of this particular report, but I'm aware that as we come out of COVID, that's something that people are looking at very closely to obviously see the impact of that, and there are concerns that we may see arise in things. So it would be good to keep an eye on that if we can. So maybe we can put that as something to look at for the future. The other thing, it was just a very minor point about formatting. Would it be possible to format these so that when we've got a proportion, the scale actually goes from 0 to 100? I wonder if that would be possible, just to make it easier to read and easier to get an impression of from a glance.
Certainly feed it back to our performance monitoring team. Just to mitigate expectations, there is that I've also raised that we do have a standard reporting across the council, so any changes to one is a little bit of a change to all, but I will certainly raise it. If we can make the change, we will make the change.
Thank you very much. I appreciate it.
Yeah, we always like easy to read reports. It's always much better. I think Councillor Long wanted to come in. Got a question?
Yeah, thank you, Chair. Again, it's a sort of presentational type comment. As you were going through some of the scores, particularly around the developmental ones on children, you spoke of some actions that you're undertaking, but the actions aren't highlighted within the report. Reading through it, some of the performance commentaries have some actions embedded within them. It's whether it's your normal practice to include your actions alongside the scorecard, particularly where they're scoring below target.
Thank you. Yes, so our standard process for the summary performance commentary to at the minimum describe what the performance is and why it is there, and with mitigating actions if it's significantly under. The reason that we haven't got it in on the specific proportion one is that just for presentational reasons, there was quite a detailed explanation, so we lifted it off the report. But as a standard, we're trying to incorporate that in, balancing against a presentation of key indicators rather than blow-by-blow analysis. But I think, yeah, standardly, we're trying to have the activity plus mitigating measures where it's most relevant.
Thank you.
Okay, so I think that draws to a conclusion the item on the scorecard, and I think we know, and so obviously Rob's got some points to go away with and perhaps a few things to work on there. Okay, so I know we've now got the item Solihull Together update. Anna's been very patient, so over to you, Anna, to present your report.
Thank you, Councillor Grinsell. Good afternoon, everybody. I'm Anna Hammond. I'm the Place Development Director for Birmingham and Solihull. You've got the report. I realise we're a bit pushed for time, so I'm not going to go through a lot of detail in the report. I would just like to highlight a few points, if that's okay with everyone. I think one of the first things that I have to say is the enthusiasm at Solihull to work differently and make some improvements for and with our communities is absolutely phenomenal, and that is all agencies we've been working with. And I think the greatest thing we need to do is maximise on those opportunities over the next few months and years. We've had, it's been quite a busy time in terms of national guidance around the integrated care system, and we have had the place guidance that I referenced, and in many ways that's really helpful. It's permissive enough to allow us to develop something at Solihull that is right for Solihull, but there's also some kind of titles and frameworks in there that will provide us with a little bit of structure and some options to move forward. Just to recap, we had our development session in June for this board, and at that point, quite early on, if not before, we talked about the role of the Health and Wellbeing Board potentially being the place-based partnership for Solihull, and actually it discharging some of its responsibilities for delivery through to Solihull Together. And one of the things we need to work on over the next few months is how we do that. Councillor Grinsell, as chair of this board, and me as chair of Solihull Together, have got some time in the diary regularly to start thinking that through. Talk in the document quite a bit about governance. One of the things I just wanted to stress is that the governance arrangements for place-based working will clearly need to be done alongside the wider governance arrangements for the ICS, so it needs to fit into that, and that's going to be a two-way process. Lots of people from Solihull are engaged in the governance work for the ICS, so we've got an opportunity to feed into that. And similarly, across the ICS, there will be what we're calling an ICP, which is the partnership across health and social care. They will set the strategy for BSOL, and it's really important that that's a two-way relationship. One of the things I just wanted to flag as well, we talked about kind of delegated responsibility earlier around finances, and clearly one of the things we need to think about, if we do take on that delegation, we also need to think about the assurance that we need to provide to ensure that we are meeting our responsibilities around that, and that's not something to be taken lightly. There's a lot of work we need to do. Just in terms of next steps then, so we've got the governance related work. We've also got a desire in Solihull to work at pace to really push forward on this agenda. So one of the things we're doing at the moment is thinking through what might those functions or areas be that we want to take responsibility for more quickly. And that may be contracts, it may be projects, it could be building on what we've got, it could potentially be some new areas, but I think there's a really strong desire for them to be practical, and actually some of the things that we can work quite quickly on and see some positive impact for our communities really over the next few months. And the third area is the finances, which I won't touch on because we had a really good discussion earlier on in the agenda. So given all that, one of the questions, or two of the questions I had to the board were around ongoing reporting for the development side of place, and I suggested some areas that you may want to consider for me to include in future reports, but also on the delivery priorities. So what I suggested in the report is potentially a mix of things. So some things may come to you annually, for example, a work programme to say, yes, we're assured, or we'd like to make some changes around the work programme. Regular updates, perhaps some thematic look at things in a little bit more detail, so you understand the background, you have the opportunity to input into the scope of some of those things. And really the delivery, so linking to the previous agenda item, how do we know we're succeeding in the areas that we've committed to make a difference? One of the things I would say is it's going to evolve. As I mentioned in the report, we're recruiting to a small team in Solihull. There's been a commitment both from the CCG and the council that we need to put some resource into this. That won't be coming online for quite a few weeks. So we know we need to make steps. They may be smaller at the beginning, and as we pick up, we can pick up pace as we get more people in the team. So just finally, perhaps just to mention next meeting. So this was an introductory report. We hope to bring something every meeting. And next time we thought we may have the first ideas for the work programme that we'd like to share with you. Perhaps a look at one of the themes, perhaps one of the better established programmes of work, and also a more focused look at health and equalities. We've got Rob on the call who contributed to the to this introductory paper, and we're currently working on an action plan around that, and similar to the previous conversation we had with Richard, looking at what good engagement might look like around that health and equality strategy for Solihull. I'm going to pause there, Councillor Grinsell, for questions or comments.
Thanks, Anna. We sort of lost you a little bit toward the end there of what we couldn't hear what you were saying. So absolutely agree that we need to have that regular update now as we are moving toward the implementation of the ICS. So I think we do need to
Oh dear.
Excellent paper, Anna. So I think it really set out everything we needed to know, and you've highlighted the next steps really well. So board members, have you got any comments to make on the paper and what Anna has already said? Are you in agreement with how we're moving forward? And yes, looking at those activities and those outcomes are going to be really key as we move forward. So members, anyone indicating? So I've got Karen Helliwell in the chamber here, so I'll hand over to Karen.
Thank you very much. Hopefully everybody can hear me. I think the commitment and the partnership around Solihull and Solihull Together and the Health and Wellbeing Board is really strong. So I would certainly like, to really get some robust timescales and progress in this area. I think we've got the opportunity to do this, and having that commitment is really important. So I think this is an ideal opportunity through this paper, I think, to get that commitment, which I'm totally in favour of. I think the only other issue for me is about the earlier point about community engagement, and the success of this is really down to the feedback from Solihull and its residents. So that measure, I think, is one I'd certainly like to see. Thank you.
Jenny Wood.
Thank you, Chair, and I'd support all of the comments that have just been made around this work, and that focus on pace that we now have, I think, is of pivotal importance. So I fully support the proposed reporting and the idea that we're going to have standard reporting here going forward on progress. I think it'll be helpful, as you've outlined, Chair, to have a progress report that gives us an update on all of the areas to make sure that pace and that visibility is maintained. But then when it's needed, separate reports on themed areas or specific proposals would come forward as and when we're needed. So we get the whole picture, and then we get that opportunity to look in detail at specific areas where needed. And in terms of that point around the community engagement, I think we perhaps need to think about how the Solihull Together partnership can develop that as it needs to be. So we'll have the Solihull Together executive, the Solihull Together partnership, and it can potentially do some work to bring in the wider community engagement as and when needed. So that will further connect us up. Thank you.
Okay, anybody else on the screens? I can't see anyone indicating. Can you?
Sunaina has a hand up, Councillor Grinsell.
Sunaina, I can see you in your yellow top, so yes, hello.
Hello, good afternoon, everybody. I just wanted to highlight, the absolute support for place-based working that certainly primary care have for Solihull Together, and all the work that Anna and all the system partners have been putting in. We're really actively engaged in it, and we're actually sort of aligning our structures and our infrastructure to work at this place-based partnership. I think we all recognise the huge pressures on the system as a whole, and the only way we're going to make things better for citizens and patients is working together at system level to make this better. And not only the acute side, but the health promotion, health prevention, all the wider determinants of health. And we're really committed to making it work. I think we have to be really careful that we get the balance right between governance and also you know, actually achieving something practical. And you know, sometimes when you start doing something, the governance structures become clearer and you tweak them as things go along. So I think it's really important that we don't try and get belt and braces of governance right before doing anything. I think we just also need to just get going with things, and then I think things will become clearer and we can nail things down. And I do welcome the fact that we're getting a place-based team together, because again, it's actually people to deliver on the ground and really engage with the community that we need. We can do a lot of work at primary care network level, but as we've heard throughout this call, there's other pressures also on primary care networks, and we are committed to the flu and COVID vaccination plans as well. So yeah, really welcome developments and excited to see where we go with it.
Thanks for that, Sunena. Yes, I know the flu and COVID vaccinations are full on at the moment, aren't they? So they're getting underway, which is great for our communities, but absolutely take on board what you're saying, and it's getting on with the action, doing the doing now. So yeah, great. So I think I can't see anybody else. Any speak up now, or we will move on. We've done quite well at catching up on time actually. So I think we've got the Better Care Fund now, and Jenny's going to present that report. Thank you.
Thank you, Chair. I'll be really quick because I'm aware of time, and actually the key messages are quite simple. So the key messages are the National BCF Policy Framework is out, and there's a summary in the report of some of the key themes. However, the detailed planning guidance nationally is not out, which means that we can't finalise the process locally. However, when we can do that, when it has been issued and we can do it, we will quickly finalise our plans. And so the third point I just wanted to make sure everybody was aware of is that once we have those plans, they will need to come here to Health and Wellbeing.
Thank you, Jenny. Any questions for Jenny on that? I think it's quite straightforward, probably no need, as she says. Okay, no, that's good. So item 13 and 14 really are only for information. We've got the work plan. Next meeting is the 16th of November. Time definitely flies. So we've got the work plan there for everybody to see. If there's anything that anybody would like to add, you need to tell us. And I think unless there's any last minute questions, any questions on those two items, I think we made it, and it's 4:05. So I think that's really good timing. I think we've had a good debate. I am really sorry for the technical problems. Those will be taken up and challenged, I can assure you, because I think it has been quite hard work for everybody this afternoon, just because of the way the meeting has had to be held. But hopefully you'll all be back here in the chamber for the November meeting, and we'll all be together. So if there's any last minute questions, anyone? No? All happy? Good. Well, thank you for your attendance this afternoon. Really appreciated, and I look forward to seeing you in November. Thank you.